increasing survival. And this just shows one of the challenges with HIV, both from the prevention standpoint and the treatment standpoint, is that a lot of this involves behavior change. And with preventing HIV infection, there are a lot of things an individual can do. They can choose to take drugs, they can choose to share needles, they can choose to be sexually active. They have the option of being monogamous. They can choose to use condoms when they're sexually active, and they can also choose to get tested. Treatment is a lot of individual choice also. They can choose to come to clinic appointments. They can choose to refill their medications, to take their pills on schedule, to obey any food restrictions that are necessary with medications, to not miss doses. The challenge, though, is the availability of antiretroviral therapy by governments. And this just lists some barriers to adherence, and why don't people take their medications? Well, some of them are structural, they're sort of external to the individual, some of them are internal, they're really based on the person's volition or desire to take medication. Big one is the availability of antiretroviral therapy, and as you're aware, there's been a rapid scaling up of treatment centers in many parts of the world, including many areas of sub-Saharan Africa, but still there are a lot of people that don't have access to treatment. And in fact, some don't even have access to clinics. A lot of the work that I'm involved in is really more focused on child survival and trying to deliver treatment for young children, both for malaria, diarrhea, and pneumonia. And one of the approaches that's being taken more and more is what actually was just discussed, is using community health workers, trying to reach out to the community and trying to deliver treatment at the community or even at the home level for relatively easy to treat common childhood illnesses, and only have a need for health facilities for more complicated situations. Drug cost is a major barrier. Governments that provide drugs for free, that's great, and that's really very helpful. But those that don't, or that have some sort of partial payment from patients, often patients will not stay on treatment because they can't afford treatment. And that's true in the U.S. as well as anywhere else. Maintaining a regular supply is really key. Stockouts of drugs occur in many places, and with antiretroviral therapy, if you have a break in treatment, especially if you take one or two of your drugs instead of all three, then you have a great risk of developing resistance to the drugs, and then the need for second-line drugs, which are more expensive and potentially more toxic. Internal, I already mentioned some of these. If once somebody starts a treatment, they need to take their medications on time. They need to refill medications on time. They may be tempted to share medications with family members or friends who are infected who have not yet accessed treatment. They need to follow food restrictions in some cases. And ideally, they should structure their medication taking around regular daily sort of habits in order to make sure they take them on a regular basis. And this is a graph actually from colleagues that I work with, a study just showing that adherence is a challenge, and there have been studies showing that the levels of adherence to treatment in sub-Saharan Africa are as good or almost better than they are in the United States and Western Europe. But a lot of people fall out of treatment, and as Dr. Punjabi just showed us, even in Liberia, with their program, they're succeeding in keeping people on treatment. This just shows the attrition rate over time of many different programs. You can see a wide range of different countries in Africa, and within 6 months, many of them have lost 30 to 40% of their patients, and within 12 months, maybe as high as 50%. So where are these patients going? Well, it's not really known, but some of them are dying because they've accessed treatment so late that it's just really too late for them really to have a quick turnaround with treatment. Some of them are having side effects. Some of them can't reach clinic. Some of them can't afford the medications at their cost, and they decide to discontinue it. But a substantial portion are being lost, and this is really a major problem that needs to be addressed. So that was just a rapid overview of HIV treatment and a little bit about adherence. I thought I'd say just a couple words, or at least I was asked to say a couple words about the Center for HIV/AIDS Care and Research, which is based at Boston Medical Center. Paul Skolnick is the chief of infectious disease, and he's also the director of the center. And the goal of the center is it's a cohesive program that brings together sort of basic and clinical research with the goals of enhancing patient care, enhancing the care of people living with HIV/AIDS. On the clinical side, we have a large outpatient clinic that has somewhere around 1,200 HIV-infected patients in care. It's, from my standpoint, as somebody who provides direct care to HIV patients, it's a great place to work. We have all sorts of auxiliary services. We have caseworkers assigned to each patient. We have a lot of sort of extra services that are available. We also have, at any one time, most of us are infectious disease specialists, but we have HIV pulmonologists. We have a full-time psychiatrist. We have an HIV hepatitis co-infection gastroenterologist that's available most of the time. So there are a lot of different disciplines that are available. So besides clinical care, there's both basic science and clinical research that are going on. There's a lot of teaching at different levels, and then some community outreach programs. And this is just a list of a lot of different programs that are going on within the Center for HIV/AIDS Care and Research. There are NIH and other CDC and Department of Public Health funded activities. The site is an ACTG site in collaboration with Brigham and Women's Hospital. There's some basic research on innate immunity of lung, lipodystrophy, HIV latency. There's teaching at many different levels within medical school and undergraduate campus, and then there are community outreach programs. And I just want to say one more thing, which is that another organization where I actually work is a place called the Center for International Health and Development, and that's based at the Boston University School of Public Health, although technically it's an EU-wide program. And our group is different. Our work is all in the developing world, and it all has to do with two things. One is doing policy-relevant applied research on HIV/AIDS, but also on child survival issues, and working closely with ministries of health in different countries, especially sub-Saharan Africa and parts of Asia, on trying to provide evidence to allow them to change their strategies, change their policies, or run their programs more efficiently. And then we also spend a lot of time trying to strengthen the capacity